The definition of castrate-resistant disease is when the testosterone is suppressed, but the disease is progressing. And conventionally, we use the serum testosterone of 50 or less as to be considered castrate levels of testosterone. So if you have the patient continued on androgen deprivation therapy, typically what we use is the LHRH analogs for this, and their disease is progressing either by PSA progression or new areas of disease, symptoms, etc., then that is considered castrate-resistant disease. I think because a number of treatments in metastatic prostate cancer, at least, have been sort of evaluated in parallel, we don't have very good comparison trials. Most of the studies have compared the novel agent to placebo and shown efficacy that way. We don't have direct head-to-head comparison trials, but in general, because these mechanisms of action of each of these agents are different, it does make sense to think about the patient's circumstances, the sites of metastases, the type of progression, the symptoms, and then arrive at a decision point as to which treatment to pick for the patient at the right time. Chances are you will be able to sequence from one treatment to another, but ideally, you want to try and minimize toxicity and still get that survival benefit when you are picking or choosing a therapy in CRPC. In terms of layering treatment, there is very minimal evidence for combination treatments in metastatic CRPC. So what evidence we do have so far suggests that layering treatments is not a good idea except along with LHRH analog therapies. So all our treatments in metastatic CRPC have pretty much been evaluated by adding them on to androgen deprivation therapy or LHRH analog therapy. So I think at a minimum that will continue as a baseline treatment, and then any other treatment is sort of added or layered on top. But within two different treatments in metastatic CRPC, whether to combine them and add them one on top of the other, the small evidence that we do have of combining abiraterone and radium-223, it appears that there is a higher risk of fractures and there was no improved efficacy. So at this point, layering of two different treatments in metastatic CRPC cannot be recommended.
Mechanism of resistance to AR-targeted therapy, based on the current knowledge, is androgen receptor amplification or androgen receptor mutation, or both. So those remain the most common mechanisms behind resistance to AR-targeted therapy, although we know there are several other factors which may come into play, such as upregulation of CMET and many other signaling pathways, such as PI3 kinase. There can be aberrations on PI3 kinase pathway, it can get upregulated. But I think the primary mode of mechanism of resistance remains aberration in AR pathway, either AR amplification or AR mutation.